Now let me discuss the other group of drugs, that is antimetabolites. Right, other group of drugs, that is antimetabolites. Now if you take this antimetabolites, remember these drugs, they act in the S phase of the cell cycle. Now in the cell cycle we have discussed G0, that is GAP0, GAP1, that is G1 phase, and then you have S phase, then you have G2, that is GAP2 phase, and then you have what is called mitosis. Now what was happening in your S phase? There was duplication of the chromosomes which was taking place within the S phase. Now if you take this antimetabolites, remember these drugs, they act in the S phase. Alright, they act in the S phase of the cell cycle. Now another important point is that these are CCS drugs. Right, these are CCS drugs. CCS drugs, that means these are cell cycle specific drugs. That means these drugs, they act only on the dividing cells. So only dividing cells are responsive. Right, only dividing cells are responsive. Now the other important point is that these drugs, they also possess the immunosuppressive properties apart from the anti-neoplastic property. So these antimetabolites, they have, right, they have immunosuppressive property, and along with this particular immunosuppressive property, these drugs, they also have anti-neoplastic effects. Right, these drugs, they also have the anti-neoplastic effects. Now within this particular antimetabolites, let me discuss the group of drugs, that is the folic acid analogues. Right, let me discuss the group of drugs, that is folic acid analogues. Now if you take this particular folic acid analogues, let me tell you the important drugs in this. The important drugs are, number one, methotrexate. Right, the important drugs what we have is the methotrexate, and the other important drug what we have is Methotrexate. Okay, so these are the two important, the folic acid analogues. Now if you take the mechanism of action of these particular drugs, remember methotrexate and as well as Methotrexate are the inhibitors of the dihydrofolate reductase. Right, both of these drugs, they are the inhibitors of dihydrofolate reductase. Right, they are the inhibitors of the dihydrofolate reductase enzyme. Next, remember by inhibiting the dihydrofolate reductase enzyme, the folic acid synthesis will not occur, and that is your methotrexate and Methotrexate. Now these drugs, apart from inhibiting the enzyme, that is dihydrofolate reductase, these drugs, they also inhibit thymidylate synthase and the enzymes involved in early purine synthesis. So remember these particular drugs, they also inhibit thymidylate synthase. Right, this enzyme, that is thymidylate synthase, and not only that, they also inhibit the enzymes involved in, right, enzymes involved in early purine synthesis. Right, enzymes involved in early purine synthesis. Now let me tell you the mechanism how it will kill the neoplastic cells. Now methotrexate, once it enters into the cell, methotrexate, it forms what is called as the polyglutamates inside the cell. Right, methotrexate forms polyglutamates inside the cell, and these polyglutamates, whichever are formed inside the cell, that helps to trap within the cell, and thus it is important for the cytotoxicity to the neoplastic cell. Okay, so what this methotrexate will do is, methotrexate, it forms the polyglutamates. Right, it will form the polyglutamates, and once this methotrexate forms the polyglutamates inside the cell, this particular polyglutamates, it helps to trap it within the cells. Right, helps to trap within the cell, and thus it is important for the cytotoxicity to the neoplastic cell. Right, cytotoxicity to neoplastic cells. All right, now remember there are certain group of individuals where they develop what is called as methotrexate resistance. Right? They develop what is called as methotrexate resistance. Now let me tell you the mechanism by which the individual develops the methotrexate resistance. So before that, let me tell you the folic acid analogues, they include methotrexate and as well as pyrimetrexate, and they are the inhibitors of dihydrofolate reductase enzyme. And not only that, these drugs, they also inhibit thymidylate synthase and the enzymes involved in early purine synthesis. This methotrexate, they form the polyglutamates inside the cell that helps to trap it within the cell, and thus it is important for the cytotoxicity to the neoplastic cells. And there are a certain group of individuals where they have what is called methotrexate resistance. Now let me tell you what is the mechanism by which the individual develops the methotrexate resistance. Now let me tell you how there is development of the methotrexate resistance. Right? What is the mechanism for the development of the methotrexate resistance? Number one, the methotrexate resistance can occur due to impaired transport of methotrexate into the cell. Right? Number one, due to impaired transport of methotrexate into the cell. Right? So this is one mechanism how there will be development of methotrexate resistance. Next, the other way how the individual can develop methotrexate resistance is there is production of altered forms of dihydrofolate reductase. So when there is formation of altered form of dihydrofolate reductase, then that methotrexate cannot inhibit the altered form of dihydrofolate reductase. Okay, so due to production of altered form of dihydrofolate reductase, right, due to production of the altered form of the dihydrofolate reductase. Now this altered form of dihydrofolate reductase, right, this is formed by the gene amplification. Right, this is formed by the gene amplification, right, or the altered gene regulation. Next, the third mechanism by which there is development of the methotrexate resistance is due to increased concentration of intracellular dihydrofolate reductase through gene amplification we have discussed. The other way is by decreased ability to synthesize methotrexate polyglutamate. How is the methotrexate acting? The methotrexate, it is forming polyglutamate, and that is causing the cytotoxicity of the neoplastic cell. So the other way of developing methotrexate resistance is by decreased ability to synthesize methotrexate polyglutamates. Right, decreased ability to synthesize methotrexate polyglutamate. Next, let me tell you the other way the individual can develop the methotrexate resistance. The other way is by increased expression of a drug efflux transporter. Okay, so because of increased expression of drug efflux transporter. So by the formation of increased expression of drug efflux transporter, what this particular drug efflux transporter will do, it will try to efflux the maximum amount of drug, right? So because of the increased expression of the drug efflux transporter of the multi-drug resistance protein class, alright. So these are the various ways by which the individual can develop the methotrexate resistance. Now if you take this particular methotrexate, remember whenever the individual takes this methotrexate, it is sequestered into the third space, right? It is sequestered into the third space, right? Into the third space collection, that is into the peritoneal cavity or into the pleural cavity or into the pericardial cavity. So it is sequestered into the third space, and what happens again is from the third space it leaches back into the general circulation, right? It leaches back into the general circulation. So once this particular drug leach back into the general circulation, this will cause the prolonged immunosuppression, right? This will cause the prolonged immunosuppression. So why it is having the prolonged action? Once the drug is given, it enters into the third space, and whenever it is required, it comes back again into the general circulation, and then it will show its anti-neoplastic activity, and that is the reason why it is having a prolonged immunosuppressive action. Next, the other important thing is, if you take this methotrexate, the clearance of the methotrexate, it depends upon the renal function, and it also depends upon the vigorous hydration. Okay, so if you take the clearance of this particular methotrexate, it depends upon the renal function, right? It depends upon the renal function and as well as the vigorous hydration, right? As well as the vigorous hydration. So renal function should be good and vigorous hydration is required mainly to prevent the crystallization in the renal tubules, right? So, right, to prevent the crystallization in the renal tubules, right, mainly to prevent the crystallization in the renal tubules. Now let me tell you one important multiple choice question regarding the methotrexate. Remember, methotrexate is the drug of choice for the treatment of choriocarcinoma, right? So methotrexate, it is the drug of choice for the treatment of, right, methotrexate, it is considered as the drug of choice for the treatment of choriocarcinoma. Next, not only in case of choriocarcinoma, remember this methotrexate is also useful for acute leukemias, right, also useful for the treatment of the acute leukemia, and not only that, it is also useful for the treatment of non-Hodgkin's lymphoma. It is also useful for the treatment of cutaneous T-cell lymphoma, right, also useful for the treatment of the cutaneous T-cell lymphoma, and not only that, this methotrexate is also useful for the treatment of the breast carcinoma, right, also useful for the treatment of the breast cancer. Next, remember, if you take this methotrexate, we can give this in the oral route of administration, and we also give this methotrexate by intrathecal route. Now in which clinical condition we use this methotrexate for the intrathecal route is, remember methotrexate can be used by the intrathecal route for meningeal leukemias, right? For meningeal leukemias we give this methotrexate by the intrathecal route. So remember, this methotrexate is given by the intrathecal route, right, that is for the meningeal leukemias, right, meningeal leukemias, right. So these are some of the very important points regarding the methotrexate. So remember, the mechanism of action of this methotrexate is by inhibiting the enzyme, that is dihydrofolate reductase enzyme, and it also acts by inhibiting the thymidylate synthesis and enzymes involved in the early purine synthesis. And the mechanism is, this methotrexate, once it enters into the cell, it will form the polyglutamate, right, and these polyglutamates, they cause the cytotoxicity of the neoplastic cell. And now let me tell you how an individual can develop the methotrexate resistance. So an individual can develop methotrexate resistance due to impaired transport of methotrexate into the cell. The individual can develop methotrexate resistance by the production of altered form of dihydrofolate reductase that have decreased affinity for the inhibitor. The individual can develop methotrexate resistance by increased concentration of the intracellular dihydrofolate reductase through gene amplification or altered gene regulation. And the individual can also develop methotrexate resistance by decreased ability to synthesize the methotrexate polyglutamates. And not only that, the individual can develop resistance by increased expression of a drug efflux transporter of the multi-drug resistant protein class. Now remember, the methotrexate has the prolonged immunosuppressive action. Why? Because this can be sequestered in the third space collection and it leaches back into the general circulation, causing a prolonged immunosuppression. And remember, the clearance of the methotrexate, it depends upon the renal function and vigorous hydration. So proper renal function and vigorous hydration is required to prevent its crystallization in the renal tubules. And the very important point is, this is the drug of choice for the treatment of the choriocarcinoma. And not only that, it is also useful for acute leukemias, non-Hodgkin's lymphoma, the cutaneous T-cell lymphoma, and as well as the breast cancer. And remember, it can also be used by the intrathecal route for the meningeal leukemias. Now let me continue with few more uses of the methotrexate. So if you take this methotrexate, right, we have discussed some of the uses. The other places where the methotrexate is indicated is, it is also indicated in the management of the rheumatoid arthritis, right, also indicated in the management of the psoriasis, also indicated in the management of the ectopic pregnancy, right, also indicated in the management of the ectopic pregnancy. Now if you take the adverse effects associated with the methotrexate, remember, adverse effects of methotrexate are the bone marrow suppression and as well as the mucositis, right, bone marrow suppression and as well as the mucositis. Now remember, now this is causing some toxicity, that is bone marrow suppression and mucositis. Now the toxicity of methotrexate to normal cells can be reduced by administration of N10-formyl tetrahydrofolic acid. Okay, so toxicity of methotrexate can be reduced, right, can be reduced to the normal cells. How? By the administration of N10-formyl tetrahydrofolic acid, right, by the administration of N10-formyl tetrahydrofolic acid. And this N10-formyl tetrahydrofolic acid, this is also called folinic acid, right, this is also called folinic acid. This is also called citrovorum factor, right, citrovorum factor, or this is also called leucovorin, right, this is also called leucovorin. Now this strategy is known as the leucovorin rescue, right, this strategy is known as the leucovorin rescue. Now this leucovorin, remember, it do not prevent the neurotoxicity, right, this leucovorin do not prevent the neurotoxicity. Now let me tell you another important point, how to reduce the methotrexate toxicity, right. We have discussed the toxicity associated with the methotrexate is the bone marrow suppression and as well as mucositis. And one point how you can reduce the bone marrow toxicity or how you can reduce the methotrexate toxicity is by administration of N10-formyl tetrahydrofolic acid. Now the other methodologies by which you can reduce the methotrexate toxicity is by doing the alkalinization of the urine. Okay, so remember, alkalinization of urine, right, alkalinization of the urine can reduce methotrexate toxicity, right, can reduce the methotrexate toxicity. Now in extreme cases of methotrexate toxicity, what you can do is the toxicity can be prevented by dialysis or by administration of a substance called as glucarpidase. Glucarpidase is a methotrexate cleaving enzyme. All right, so in extreme cases of the methotrexate toxicity, this particular toxicity can be treated by dialysis, or it can be treated by the administration of an enzyme which is called as glucarpidase. Glucarpidase is what? It is a methotrexate cleaving enzyme, right, it is a methotrexate cleaving enzyme. Next, when you use this methotrexate for long term, Long-term use of methotrexate may lead to hepatotoxicity, pulmonary infiltrates, and even the pulmonary fibrosis. Long-term administration is associated with hepatotoxicity. It is associated with the development of pulmonary infiltrates and as well as associated with the development of the pulmonary fibrosis. Next, let me tell you, there are certain drugs that is called as the NSAIDs, that is non-steroidal anti-inflammatory drugs. NSAIDs like aspirin, penicillins and cephalosporins may decrease the renal excretion of the methotrexate and they will result in the methotrexate toxicity. Okay, so the drugs like NSAIDs, that is aspirin, right, drugs like NSAIDs like aspirin, then penicillins, and then cephalosporins, right, and then cephalosporins. Remember, these drugs, right, these drugs, they will decrease the renal excretion, right, these drugs, they will decrease the renal excretion of methotrexate and they will result in the toxicity of the methotrexate. Now, you have a similar drug to that of methotrexate which is called as pralatrexate. Pralatrexate is a similar drug indicated for peripheral T-cell lymphoma, right? We have a drug called pralatrexate. Pralatrexate is a similar drug indicated for peripheral T-cell lymphoma, right? Peripheral T-cell lymphoma, right? Let me shortly revise here. Methotrexate is also used in the treatment of rheumatoid arthritis, psoriasis and ectopic pregnancy. The adverse effect associated with the methotrexate is it will cause bone marrow suppression and mucositis. And the toxicity of methotrexate to the normal cells can be reduced by the administration of N-10-formyl tetrahydrofolic acid, which is nothing but folinic acid or citrovorin factor or the leucovorin. And this strategy is known as the leucovorin rescue. And the leucovorin do not prevent the neurotoxicity. And how can you reduce the methotrexate toxicity is by causing the alkalinization of the urine, and in extreme cases the toxicity can be treated by dialysis or the administration of the glucarpidase, which is a methotrexate cleaving enzyme. And long-term use of methotrexate may also lead to hepatotoxicity, pulmonary infiltrates and pulmonary fibrosis. And you have drugs like the NSAIDs like aspirin, penicillins and cephalosporins. They may decrease the renal excretion of methotrexate and they result in the toxicity. And you have a similar drug which is called as the pralatrexate, which is indicated for the peripheral T-cell lymphoma. Now let me tell you the uses of methotrexate in the form of a mnemonic, right? Let me tell you the uses of the methotrexate in the form of a mnemonic. The mnemonic is methotrexate, right? Methotrexate inhibits the cancer, right? This is the mnemonic. The word I stands for methotrexate is an immunosuppressant, right? It is an immunosuppressant. The word C stands for Crohn's disease. The word A stands for used in the treatment of abortion. The word N stands for used in the treatment of non-Hodgkin's lymphoma. The word C stands for used in the treatment of choriocarcinoma. The word E is ectopic pregnancy, right? And the word R, it stands for rheumatoid arthritis, right? Rheumatoid arthritis. So remember, these are all the clinical conditions where we use the methotrexate. Now apart from this methotrexate, within this particular folic acid analogues, we have another important drug which is called as pemetrexate. Let me tell you few points regarding the pemetrexate. Remember, pemetrexate is approved for the treatment of mesothelioma, right? Approved for the treatment of the mesothelioma, right? Mesothelioma is a tumor which is originating from the pleura. Now, the other important point regarding the pemetrexate is, remember, in order to decrease the toxicity of pemetrexate, we give folic acid and vitamin B12 supplementation. So remember, folic acid and vitamin B12 supplementation, they will decrease the toxicity of pemetrexate without interfering with its clinical efficacy. Alright, so the toxicity of pemetrexate is reduced by the administration of the folic acid and vitamin B12. So remember, the folic acid and vitamin B12 supplementation, they will decrease the toxicity of the pemetrexate without interfering with its, right, without interfering with its clinical efficacy, right. So that is a very important point regarding the pemetrexate. So this completes the discussion on the folic acid analogues.